We're going to talk a few cases just to highlight, I think, some of the, obviously you've heard a lot about different regimens and different agents and how they may pertain to you, but also obviously how there are more than one option that may pertain to you as well. So I thought I'd highlight a few just to hit home a few key points. But again, you know, we'll discuss them, and if you have questions, for sure, at the end, we have room and probably hit more than one speaker. So I showed you this before just to remind yourself about, so when do folks need treatment? And as I said, everybody is different. So we really, we look for the development of worsening of your blood counts. But remember, part of that is based on the individual. So if somebody is, I'm just throwing a number out there, their hemoglobin is 10, but they've been that way for a long time and they're feeling fine, it's not an actual number that we go, oh, that's it, that's the number, they met it, it's time to go. Part of that's based on your symptoms and other parts of how you're doing and other regards to your disease. So again, what may signal treatment for one person may not signal treatment for another person. And so I just want to take that off the bat. So typically in general, if you have worsening blood counts or growing lymphadenopathy and you're becoming more symptomatic, you know, that's the time that your physician's going to sit you down and say, let's start planning, okay? And it's rare, although it does happen, it is rare that somebody with CLL needs emergent treatment. I will never say that doesn't happen. It does, but it's not as common. So most of the time, because of the tempo of how your physician is seeing you, you can sort of get a sense of what's going on, and hopefully between the conversations between you and your physician, you're sort of building up to say, you know, I see a change, I might want to bring you back a little sooner to see if that's a real change, let's see how you're feeling, I'm going to watch you a little closer, and then you can sort of plan the next, you know, the next steps regarding treatment. So it is, you know, something that usually can be a little bit of planning that is involved because there might be other stuff going on with your life. And those can interfere as well. And sometimes, there's no doubt many of the physicians have altered the timing of treatment also based on significant family events, as long as somebody's doing okay. We've all done that, and so certainly it is a planning, you know, the good news is you can plan together. So let's just say that. Again, I just want to reiterate that sometimes your doctor might be looking for other reasons if it doesn't just seem CLL based. So when we talk about when and how, just keep that in mind. Okay. And again, before I hit the cases, all the features that folks have already spoken about this morning will resonate with options of selection. So we're going to go through that. So remember, it's not only your disease characteristics, it's also your functional status, your other medical problems, and perhaps medications that you might be on too. Okay, so we all take that into factor. So again, one size does not fit all. So that's the disclaimer, because I don't want you to walk away and say, that case is me, and Dr. Lamanna said I needed that, because your doctors are going to kill me. Okay. Okay, so let's talk about case one. So this is just an example of a patient who is about the median age of CLL folks. So here's a 73-year-old gentleman who is diagnosed, he has a trisomy 12. He has a mutated IGVH status, and he was diagnosed 5 years ago. He's without any symptoms, and he has small lymphadenopathy, no splenomegaly, and his only other medical problems are some hypertension and some diabetes, and those are his blood counts. So even though he has an elevated white count, his hemoglobin and his platelets are fine. He obviously has small lymphadenopathy and no splenomegaly, and he's without symptoms. We would advocate watch and wait. So I know that many of you, who in the room, and again, if you're not fearful of showing hands, are in the watch and wait, watch and worry category? Okay. Less than a year? Okay. Less than 5 years? More than 10? There you go. There's some out there. Good for you. So, you know, when we talk about your white count and that tempo and that trajectory, so if your white count is creeping up, and this is what's the variability, over the years, there are some people who may rapidly rise, but then plateau for a while, then rapidly rise again and plateau for a while. So it shouldn't be that the white count triggers, oh, it's a high white count. There may be a concern if somebody takes a big jump in a short period of time, but again, I would advocate that you come back sooner Let me see if that's real. What's going on? Is there a change in the tempo that I need to be concerned about? But if you're completely without symptoms and your other counts are fine and there's no bulky lymph nodes and you're doing well, we would watch. Okay. Let's go to case 2. And this will highlight some of the points I think people brought up earlier. So Tom is a 62-year-old gentleman, a little younger. He was diagnosed with CLL deletion 13q, and he's mutated. So he was diagnosed 7 years ago. So that's a young person with CLL. Okay, but now he presents with progressive fatigue. He's got some small lymphadenopathy, and he has palpable splenomegaly. He has some hypertension, but here's his blood counts. So now he's starting to get more anemic. His hemoglobin's declining. His platelets are slowly declining. And as I said, he's now got progressive disease because he's now having progressive fatigue. So now this I put because, as I said, there's probably more than one right answer here. Okay, so this is the group that when you talk about chemoimmunotherapy, or FCR, this is a discussion that can be held with this patient, right? Because he's young, you think he can tolerate this regimen, perhaps, because he's younger and fitter, and he's on very few medications, assuming his kidney function is normal. And that subset, which I'm going to go through, this is one of those discussions that you would have. But ibrutinib would certainly also be an option for him. So let's say he said to you, you know, doc, I've read about FCR. I don't like the late-term side effects. Seems that the ibrutinib data is very good. Could he go on ibrutinib? Sure. So this is that conversation that we have to have with folks, that there's more than one option. This is just still a subset where chemoimmunotherapy might be appropriate. Okay. And this is that curve that others showed you before, looking at how there's a long-term group who are mutated, who are still doing well, who had FCR many, many years ago. So this is where you might still have that conversation. Okay. When we talked about FCR and BR, he is a little bit older, so some people may say, you know what, I don't want to do FCR. What about the toxicities of BR? So this was that randomized study of FCR versus bendamustine and rituximab. And you can see that the overall response was about the same, but the complete remissions were slightly higher with the FCR subtype. And so again, when you're talking about toxicities, so BR is not, this is something that could also be considered for this person, knowing that the response rate may not be as high. But certainly there's less toxicities with bendamustine and rituximab versus FCR. So this certainly is part of the conversation if somebody was adverse to the intensity of FCR. Okay. Now let's talk about an older patient. So here you have a 77-year-old person who's deletion 13q and mutated. Past medical history, a little bit more medical problems, coronary artery disease, some hypertension, mild CHF, and hyperlipidemia. Has been followed on watchful waiting, and now he's also experiencing more fatigue, lymphadenopathy, and splenomegaly. His white count is 105, hemoglobin's 9.5, platelets are slightly under 100. Which options would you recommend for Cal? This is an older person. So now there's a lot more options here. So, you know, previously, before we had all the new agents that we've been discussing, you know, our options for older folks were really quite awful. In the sense that most of the clinical trials that we ran were really on folks that were 10 to 15 years younger than the median age of the disease. So then when you took FCR and you gave it to somebody who was 75 with bad kidneys, no wonder why they got so sick. So, you know, over the last 10 years, we've really come a long way with trying to do clinical trials on more age-appropriate patients that are really the median age, the average age of patients with CLL. And so I think we've really come a long way. Now, to be fair, now you have all these novel agents, and these novel agents are not age-specific, with the exception of the fact that there's a lot of concomitant medication issues that can come up depending upon what folks are on for their hypertension, diabetes, heart disease, atrial fibrillation, yada, yada, yada. So when folks are then deciding about, now you have many more options of therapy. Now we've got more to balance. We've got more to talk about, but we absolutely have more to balance. So the likelihood is we probably wouldn't give Cal FCR because he's 77 and he's got a lot of other medical problems. Chlorambucil and a monoclonal antibody, you saw some of that data earlier, and I'll show that to you briefly. That's certainly an option. So he's got good risk features, and even though he's got a lot of comorbidities, could you consider chlorambucil and an antibody? Yes. Now, let's talk about chlorambucil for a second, because it's obviously the oldest oral form of chemotherapy we've had for CLL. So what old has become new again. So you've seen that, in the US, many of us haven't used or sort of got away from using chlorambucil once the monoclonal antibodies started, once rituximab and all these other monoclonal antibodies came into use, because it was the go-to for sort of supportive care in the sense that less than 5% of patients would get a response, a complete response with chlorambucil. So it was really, when we had FCR, you couldn't, if you were older and frailer, you weren't going to get FCR, so there was chlorambucil, but when rituximab came around, then a lot of people were using single-agent rituximab rather than chlorambucil because responses were a little higher. Okay, so that's where that came from. So then all of a sudden there came this data that if you combine chlorambucil with an antibody, certainly there was synergy, and yet still not as much toxicity as what we would see with FCR. So certainly this has definitely become an attractive option for older folks who may have other reasons that perhaps, whether it's access to some of these new therapies, affordability, or because of their concomitant medications, may not be eligible for one of the new agents. This certainly may be an option, and many of you might have received one of these combinations. So certainly chlorambucil and a monoclonal antibody are an option. Now, ibrutinib is certainly an option as well. However, all those medical problems that I suggested that Cal had, you need to think about. So obviously there is, as was reported earlier, there are some side effects with ibrutinib, and some of you might have unfortunately been subjective to some of those side effects. Now, obviously compared to drugs like FCR, this is a walk in the park. However, there's still some significant side effects that people come off drug for. And so the issues with ibrutinib are the cardiac arrhythmias, the atrial fibrillation, and others. It's not just AFib. Yes, it happens only in about 10 to 15%, but our older population is already more prone to AFib. So that's something to be considered. Then if you're already on an anticoagulant agent, we know that there's an issue of bleeding issues with ibrutinib. Now that doesn't mean it can't be used, but certainly that has to be discussed. So it's that conversation of you're on you're on Coumadin or you're on Xarelto or some other agent, and we're putting you on ibrutinib. You have to understand that there's an increased risk of bleeding, and is that something you're willing to accept? It's major bleeding risk is low, so less than 5%, but it's not nobody. So when you're balancing all these issues with your patient, it's discussing all this and really figuring out what is in the best interest not only for the patient's disease, but patient preference too, and what's available. So that has to be considered. So ibrutinib is certainly an option depending upon the medications that the person's on, but it has to be discussed. And of course, I'm always going to put clinical trials in there. And that was all those questions about clinical trials is great. I have to say, of course, clinical trials, even though I'd love all of you to be on a clinical trial, it is a lot. So it's not going to be, one is your access, two is whether or not you have the support. Some of the clinical trials might have some travel reimbursement issues, but others do not. There's no doubt there are different clinical trials running at different centers, and not every clinical trial is appropriate for every person. I'd like to say that probably we would like to say that obviously the folks running the clinical trials have the best heart and mind for the patients who are on the studies. And certainly, but it's a lot more labor intensive, both for you as the patients, but and the physicians and the staff. You will have more visits, and so you have to factor that in about whether you think that might be an option for you. So you just have to take that in consideration. But certainly, obviously, without the clinical trials, we wouldn't be advancing the field as much as we have. So options for older folks, again, median age is 72. Many obviously don't, many of you folks who are older and recently diagnosed may not need treatment for many years. So again, think of that, because when we think about treating folks, they could be in their mid to late 70s or early 80s before you need therapy. And as I said, for FCR is probably not an option we give many folks who are older than 70 because of the increased toxicities, both the myelosuppression or decrease of their blood counts, as well as immunosuppression or increased risk of infection. So you don't see many older, we usually are very selective about if we think somebody's very fit to get FCR. but again, probably only in that small, mutated, favorable patient population. Antibodies, as I said, just to show you the data that I already mentioned, antibodies and chlorambucil are certainly an option. Again, you can see that there are high overall responses, not necessarily complete responses, but certainly a high overall response to the combination of chlorambucil and an antibody. This is just some of that data, antibody and chlorambucil versus chlorambucil alone. So certainly I think it's a benefit if you're older and considering using chlorambucil. Probably an antibody with chlorambucil would be better unless there's a reason you can't versus chlorambucil alone. Okay, and then again, this is the data that was shown earlier that led to the approval of ibrutinib in older patients with CLL. So ibrutinib is obviously approved for CLL who are older folks. So it's not just chemoimmunotherapy or chlorambucil and an antibody, but ibrutinib is approved as well for older folks because of this data. And again, you don't have to belabor the curves, but you can see the PFS is certainly better with ibrutinib versus chlorambucil. So that's what led to its approval. So these are all options that are now non-age restricted. Whether you're young or you're older, ibrutinib is an option for treatment. Just depends on what the other issues are that may impact whether you're going to use ibrutinib or not. Okay. And then the last case, see, I'll get you back on time. Case 4, Fred. Fred's a 60-year-old gentleman who was diagnosed with a 17p deletion and is unmutated, and he was diagnosed 6 months ago. So he's presenting with progressive disease quite rapidly. So he's fatigue and lymphadenopathy, palpable splenomegaly that's down about 7 centimeters below the costal margin, so 7 centimeters below your ribs, so you can feel this. He has hypertension only, and his blood counts are what you see there. So what's the optimal treatment for this person? Now again, there's probably more than one right answer, except not chemoimmunotherapy alone. Okay, so now before we had the B-cell receptor agents, I think that's a fair question. I think that was fair. So before we had all these new agents, we only had FCR, other chemoimmunotherapy combinations, alemtuzumab, for those of you who might have been, I don't know if anybody's had alemtuzumab in the audience. That's how alemtuzumab got approved, was for relapse refractory patients who had a 17p deletion who failed fludarabine-based therapy, another toxic agent. So this is what you had. But now that we have data that shows that the novel agents, and I don't mean just ibrutinib, but unfortunately, remember, ibrutinib's only approved in frontline, venetoclax is in relapse, or any of the other B-cell receptor agents. These agents, no doubt, have really tremendously changed the survival of patients with this chromosomal abnormality. And so I am not an advocate of chemoimmunotherapy unless there is some really good reason that they can't get a novel agent. And again, you have to figure out what novel agent might be appropriate and what might be based on. But chemoimmunotherapy alone shouldn't be used for 17p deleted patients. If you're on a trial, and a trial has a novel agent plus something else, that's fine. But I think this is the one point I want to hit home for most folks is if you have a 17p, you should get a novel agent. Okay, we could talk about what might be better or not, but you know, that's fine. And hopefully the clinical trials will show us which might be better, but I think part of that will also depend on your medical problems, what your availability, and so on and so forth. But it should be a novel agent plus, or a novel agent alone. So I think that's one game changer that we've had over the past couple of years that we can comfortably say that the novel agents have absolutely done better when you look at those curves compared to chemoimmunotherapy. Now what happens, and this is where relapse is difficult, so I didn't want to do a whole bunch of relapse cases because, and I'll talk about that right after this, but I thought this would be important. So if you should get a novel agent as frontline for 17p deletion, let's say ibrutinib, since that's approved, then what do you do if you relapse? Because remember, we know that folks who have a 17p deletion, even though the standard therapies are now the novel agents, and you saw curves that others showed earlier this morning, they're still going to drop off. So these folks aren't cured of CLL, and so we have to look for other agents. And so here's where, as people mentioned earlier, venetoclax would be certainly a very good choice. if it's available. Could you go to, instead of a BTK inhibitor, could you go to a PI3 kinase inhibitor? You could. There is some data, though, that we're not sure. Remember, they're part of the same pathway, so we don't know how long, if you switch from ibrutinib to a BTK to PI3, how long that will last, because those pathways hook up. But certainly you can do that. But we have to look for alternative therapies for this group. So certainly venetoclax and a monoclonal, plus or minus a monoclonal antibody. What about CAR T cells, which you guys are going to talk about later? Very exciting, so I'm not going to delve much into that, but certainly CAR T cells on a clinical study. I realize it's not approved yet for CLL, approved for ALL patients and some relapsed non-Hodgkin's lymphoma patients, might be an option on a clinical trial. And transplantation, we don't talk much about transplants, do we? Now again, transplants for CLL patients really hasn't made, remember, it's an older patient population. So the problem is transplant has been nixed for most of our patients because you guys are older and have all these comorbidities. And so that's really the unfortunate thing about transplant, is just that it's not really pertains to our group of patients. However, as transplant toxicities have lessened, there's no doubt the age has pushed, that we are transplanting some older folks if they're fit with CLL. However, again, it's really regulated to a very small patient population who are going to go on for a transplant with CLL. And so that may be an avenue where CAR might be available, or again, because you have all these novel agents, sequencing of these agents until we have more new agents, or we have better combinations of these agents, really has relegated transplantation for CLL way down here. Okay. We will still take some very young, aggressive disease patients who are in their 50s and have blown through lots of chemo, blowing through the new agents to a transplant, absolutely. But I could tell you in the past 5 years, I think I've taken only about 3 or 4. So it's really relatively uncommon, okay? But these are certainly all things to consider. Now, in the relapse setting, again, this becomes a little tricky. So somebody had asked about, they had gotten fludarabine over, my math, 11 years ago? Good job, like 11 years ago. Can you treat with chemoimmunotherapy? That's what we used to do. So if you had a long response duration to whatever chemoimmunotherapy or chemo drug you got, and it was 5 years or more, we didn't have the novel agents, absolutely. Now, but that's 11 years ago, and so the question is, how are you now? So again, the same considerations still go to, how many more medical problems do you have? What drugs are you on? Do you think you can tolerate a purine analog-based chemotherapy regimen? Those factor in, and then has anything changed about your disease characteristics that we need to know about, right? That would influence the choice of care. So relapse becomes a little bit, very complicated, which is why I'm not going to show you any of those cases, because we have lots of arguments, even with the same people in the room. But you have to factor that in. And so side effects of prior treatment, the other medical problems, response duration of prior chemos, disease characteristics, those are the choices that really get, and it becomes quite artful because there is no direct algorithm. I mean, hospitals have come up with what we'd like to do, but it really has to be an individual basis depending upon, each of the influences of what's going on with you guys, your comorbidities, your medications, and your disease that in fact impact what you're going to get. And again, whether or not you have ability to obtain some of these novel agents, costs, so on and so forth. So there's lots of things that go into factor in relapse, even more so than in frontline, what you may be able to receive in relapse. And so those are conversations that are ongoing, obviously, between you and your physicians, and really you have to weigh in all these factors. And sometimes what might be the right choice, medically based on your disease, may be completely not feasible for you, or completely out of your pocket expense. So until, hopefully as we advocate more on your behalf, and hopefully you guys all do that from a patient advocacy group and continue to do that, and there are second generations of these drugs that are coming down the pike, second generation of the BTK and PI3 kinase inhibitors that will hopefully have less side effects than the current ones that are available. And hopefully if the more get approved, the price may go down. there might be more options for more folks. But we got lots of challenges, but there's lots of hopes, because think about all the therapies that are now available for folks with CLL. So stay tuned. I'm going to end there for questions.
I have a question about dosing. So there's been discussion lately about, specifically I think about ibrutinib, is in the real world post-trial now, is there a lower effective dose for many patients, and can that lower the cost? Where are we now with trying to understand, can someone have a lower dose of one of these novel therapies?
Yeah, I mean, I think this is not going to be a clinical trial that gets done. But obviously there are folks, and many of you actually might be doing this now, there are many folks who have side effects where your dose of ibrutinib has been reduced. And so anecdotally, and hopefully we can put this together, there are some CLL groups that are actually trying to collate this data together about whether, what's going on with the folks who are on lower doses. There were some initial publications about this that looked very bad, the initial ones. But these were when ibrutinib just got approved for the multiply relapsed patients. And so stopping and starting doses for different reasons, they would progress very quickly. But this is in that era of, again, folks that had no other options, that all of a sudden, had multiple lines of chemotherapy, and ibrutinib was, the godsend, the next drug available for them. And no doubt it still, increased their survival, but eventually they were going to progress, right? So these are not, again, these drugs aren't foul-proof for anybody. People still relapse on these oral therapies. But in that patient population, for the multiply relapsed, it looked very bad if you either held dose or dose reduced. And so I don't think that we'll ever run a trial about looking at different dose levels due to expense and the competition with other agents, but I could be wrong. I don't control that. But certainly there's no doubt that many of you might be on a lower dose and doing just as well. And I think that certainly that is a reasonable thing to consider. There's, again, hopefully we can pool some of the data, but I think that absolutely patients possibly can be on a lower dose.
In your chart, one of the factors in deciding for treatment was symptomatic enlarged lymph nodes over 10 centimeters.
Can it be less?
Can be less. What if not symptomatic enlarged lymph nodes?
Yeah, so that's a good question, right? So, and this goes back to that whole issue about scanning and physical exam issues as well. So let's say you have bulky lymph nodes, and I use that as a very obviously extreme idea. 10 centimeters is pretty large, but let's say you have 4 to 5 centimeters, but you're completely fine. No, we would advocate watching you. And again, the tempo of that growth is something that, again, there are folks that may have had, just like having a high white count of 200,000, but you've had that for a very long time, right? There are some people, when their lymph nodes grow, they may not grow. They grow very slowly over the years. So if you're asymptomatic and the lymph nodes are large but not causing you a problem, we would advocate you would be watched. So it's still asymptomatic, whether it's due to your blood counts or due to the lymph nodes, it would still pertain to both.
Related to that, if are enlarged lymph nodes more difficult to treat than small? Is the treatment as effective in an enlarged lymph node as one that's not so enlarged?
Yeah, fair enough. So that's a very fair question. And it really does, it has to do with the biology of the disease. So with the novel agents, of course, one of the most impressive things, and many of you have probably seen this with some of the pictures on the internet or may have even experienced some of this, that you've seen is that what the most impressive things with some of these novel agents is how quickly the resolution of these enlarged lymph nodes can be. Now, you're absolutely correct to say, well, so what happens if you wait or the lymph nodes get bigger over time? So part of this is still based on biology. So if you're somebody who's really had favorable disease characteristics, and this has been slow growth, again, going back to the tempo, slow growth over years, then we would still expect you to be extremely sensitive to therapy as your frontline therapy, regardless. But let's say you've had multiple treatments for your CLL over years, and the lymph nodes really start rapidly growing back and becoming a problem. That's a disease, you know, aggressiveness that has obviously changed, and it may be less responsive to therapy regardless of the therapy because the disease is getting more resistant. So it's still, you have to sort of take each case individually. Obviously, one of the things that we are looking at, when I talked about that, right now we're waiting until patients need treatment, you know, make indications for therapy either based on blood counts or lymph nodes. There are trials that we're waiting data on, so they are closed, looking at in high-risk individuals, whether or not starting, because the novel agents have less toxicity than some of we tried to do this with chemoimmunotherapy, early intervention versus being observed, let's say with chemoimmunotherapy versus monitoring until you really need treatment, but rightfully so, those studies closed because nobody wanted to be enrolled. Nobody wanted to say, if I don't need FCR right now, and you're gonna randomize me and I don't need treatment, nobody wanted to get on those studies. Right, so aggressive therapy, if you didn't need it, but with the novel agents, those trials are being run and some of them are actually closed. So whether or not high-risk individuals, starting them when their lymph nodes and their blood counts are better, may change their overall survival, that's a question that I think is a fair question to have evaluated now in the era of these new drugs.
Is there any relevance in the treatment toolkit for lenalidomide, which really hasn't been mentioned too much now, and because you brought up alemtuzumab, I was wondering if the sub-Q administration of alemtuzumab has relevance to any type of therapy.
Let's talk first about lenalidomide. Lenalidomide is absolutely an active agent for CLL. And there's been lots of studies looking at lenalidomide. I do not, even though it has, I don't know what the label is in Canada. In the US, it's more of a compendium, so you can get it approved. It doesn't have full-blown CLL approval, but it has a compendium use, so I don't know how it works here. It what? Okay. So, but certainly there's absolutely activity of lenalidomide in CLL. Now, the tricky thing, the reason why I think lenalidomide is less utilized in CLL was also, although when you start comparing now all these new agents, not too dissimilar to some of them, you know, the issues of tumor lysis and tumor flare became an issue, and cytopenias, became a difficulty with physicians to use the drug. Not for folks who used it, so I guess I should publish my paper on lenalidomide, which I haven't, but the MD Anderson folks have, and others, and certainly it's absolutely, and here in Canada, it's absolutely an active agent. You just have to be, and there's a role for looking at, you know, how to use the image in terms of attacking the microenvironment and other aspects that keep the CLL cells alive. That certainly it's something that I don't think it'll be in clinical trial. There are other clinical trials, so lenalidomide hasn't completely gone away. But I'm just saying with the other agents that are now available, I'm gonna make a leap and say that many physicians are not gonna go back to it unless the data is so compelling because of all these new agents and less side effects and the ease of use. But do I think it has activity and decent activity? Absolutely. So I think it's one that will remain right now still part of clinical trial land, and those are really small investigator-initiated studies that are still utilizing lenalidomide. But it's got activity. But I don't think it'll go full-blown unless we show some combination is so much better than other drugs. And then to your next question about, I could talk about lenalidomide a long time. We could do that offline. Alemtuzumab. Now that, you know, that is now, at least in the US, you can get it free to use it, although you have to request it. So most pharmacies don't carry it. Sub-Q, I was using sub-Q even a while back. But the problem is, again, the myelosuppression and immunosuppression with alemtuzumab, even though the sub-Q is an easier form to use, still occurs. Do I think, are there subsets of patients who still could benefit, and particularly rare parts of this, like pure red cell aplasia? Absolutely. And in fact, I can tell you I've used it in the last 5 years. Several patients who had pure red cell aplasia, very rare group of patients, but if you see enough CLL, it occurs, and alemtuzumab absolutely is effective. So it won't, again, because of the toxicity issues, even as a single agent, so forget alone combinations that were done, it won't make mainstream. But I think obviously, depending upon what the needs of the patient are, if it's available, hopefully they won't get rid of it because there's still some other non-CLL indications that it's used for. It obviously does have significant activity.
Could you comment on whether there are any ongoing studies that are open or whether there are any that have now closed that have looked at FCR for shorter durations, say 3 months, adding to that a drug such as ibrutinib for a defined period of time as opposed to a forever, and whether or not that is or you think will be considered a new gold standard to avoid the long-term side effects of the chemoimmunotherapy regimes?
Are you like a clinical trial plant?
No, I'm the spouse of somebody who's currently in watch and wait, and that, or watch and worry, and she watches, I worry.
Aw, good for the caregiver side. All right. Absolutely. Actually, that trial's being done now. So there's no doubt, let's go historically. Oh, you just need to cut me off when you want to. There's no doubt that we've looked at, before the novel agents came, we looked at different FCR light, sequential FCR, different ways to try to utilize FCR to make it safer. Or less cycles, and it's still pretty much the same. So now, you're absolutely correct, there are clinical trials that are looking at chemoimmunotherapy regimens along with the novel agents. Now again, that's going to be more toxicity than if you use the novel agent alone, but one of our questions that many of us want to look at, obviously, is can you, like you said, shorten the duration of FCR or another chemoimmunotherapy regimen, combine one of the novel agents such as ibrutinib or venetoclax, and see whether or not then, instead of staying on oral, because right now, for those of you who might be on, unless you're part of a clinical trial, the way we've been strategizing the novel agents is that if you're on it as a monotherapy, you continue it unless you're having some intolerable side effect or your disease starts progressing. So that means lifelong oral therapy right now. Obviously, what we're trying to move away from is, do we need that? Obviously because of financial reasons, but do we need that? So there's a whole bunch of, obviously, implications about wanting to try to do this, and so by combining agents together, of course, we know that you can enhance the response rate of the novel agents when you combine them with antibody or other chemotherapy drugs. And so there might be a way to strategize looking at that. And so actually some of that initial data with FCR 3 cycles and ibrutinib was actually initially presented recently at one of our major meetings. And obviously the data is very immature, looks very favorable because the responses with FCR alone are so high in the frontline setting. So certainly the responses look great, but then the goal would be that there be finite therapy of the ibrutinib as well, because you might be able to get, and this is where I bring up the bone marrow thing that I alluded to in the morning. The way to look at this, of course, would be to look at people's bone marrows to see if they've completely eradicated their CLL, so that we can look at, well, how long will that last if we stop the oral drugs? How long will that response duration last? And if eventually somebody relapses, can you restart their oral therapy and will they be sensitive again? So these are questions. So absolutely, there are clinical trials running now. And again, for many of you who might be interested, you can get online and you can look at there's a clinical trial, obviously, websites that you can look at and look up your disease type and try to find clinical trials that might be suitable. And if you have questions, reach out to those sites to see if it's something that might be feasible or not, but at least you could see what's going on. So those studies are being done now. Stay tuned, absolutely.
I read somewhere recently that the manufacturer is repackaging within the next 4 months ibrutinib into 4 levels of dosages, but they will all cost the same, regardless of the difference in dosage. Is that true?
Yes. Yes. I don't know what to say. It's true. I have no good answer for you there. That's it. So you guys will be getting, for those who might be on, yes, single agent pills, and yes, they might. We have to work on this.
There's been a lot of comments about the 17p deletion being a predictive factor, but is the mutational status something that is going to become also more predictive in nature for clinicians and doctors?
I do, yes. So there is already emerging data now that, and Carolyn had already mentioned this, about how patients with unmutated versus the mutated folks, the response duration is typically shorter than chemoimmunotherapy. And so I think as this becomes more readily available, there will also be a push probably for those individuals as well to probably move away from chemo. It could be chemoimmunotherapy plus, again, a novel agent, but I think the data will become stronger that there might be a push to move those individuals towards novel agents as well, given those disease characteristics, so absolutely.